Hi guys, today's topic is tumors of the bronchi and lungs. So let's begin. So some key facts to start this question with are the classification basically into benign, malignant, and pseudotumors. So for lung tumors, it's ideal that you give this uh, pointer in the start that you can divide them into benign, malignant, and pseudotumors. Then most benign tumors are made up of mesenchymal origin and malignant of epithelial origin. Also, when we talk about tumors, we need to tell whether the primary or the secondary tumors are more common. So here in the case of lungs, the secondary tumors are more common than primary tumors. For example, ovarian carcinoma, ovarian cancer, breast cancer, or colorectal cancer, mainly because of the a rich blood supply of the lung. So via the hematogenous pathway, these cancers spread quite easily to the lung, metastasize to the lung. The risk factors for lung cancer very obviously include smoking, radon, asbestosis, and pollution. Uh, and it is the second most common cancer in the world. So see, these are some of the facts which are good to begin your answer with in your final exam. So first of all, like every question, we start with the classification here. And like I said in the previous slide, the classification of lung tumors is mainly divided into pseudotumors, benign or malignant. So what are the pseudotumors we need to talk about? Well, in pseudotumors, we need to talk about mainly tuberculoma. It is a special form of chronic primary tuberculosis. It has alternating layers of caseous necrosis and granulation tissues, which form like a mass-like lesion in the lung, giving it the name pseudotumor because it's mass, but it's not neoplastic, so it's pseudotumor. Okay, so now the more important parts, benign tumor of the lung. Well, here you need to name them mainly rather than talking about them in too much detail. You need to talk about you need to mention lipomas, lipomas from fat tissue, leiomyomas from smooth muscle tissue, chondromas, chondrohematomas, very common in the lungs, so you need to talk about them, papillomas and adenomas, and just briefly describe chondromas, chondrohematomas, papillomas, and adenomas, so that your examiner knows that you know what they actually mean. So I've written the basic description for these terms here. Leiomyomas and lipomas is clear as I already told you. Chondromas are made up of cartilage, so they're tumors, benign tumors from cartilage tissue. And chondrohematoma is disorganized but mature cartilage tissue and very common in the lungs. Um, what your examiner will be focusing on will be the malignant tumors and their classification and further details. Malignant tumors of the lung are divided into small cell carcinoma and non-small cell carcinoma. You will see many classification for lung tumors online, but the one which is followed by LF1 is this one, small cell carcinoma and non-small cell carcinoma. So you may forget any other classification, but please do not forget this classification for malignant lung tumors. So this is just this classification of WHO 2015 from one of the past presentations of the patho department. But even if you forget the WHO classification, that's okay. But if you, like I said, forget the main classification for LF1, which is non-small cell and small cell carcinoma, that is that will be a terrible mistake. But let's go through this once before we come to the actual one which we need. So what is the WHO classification according to 2015? So we start by dividing it into, first of all, adenocarcinoma. It is the carcinoma made up of glandular tissue and located in the periphery of the lungs. And it has several histological types: papillary, macropapillary, acinar, mucinous, lipidic. You don't need to know too much in detail, just know a few names about of these so that you can say them in the exam. And whom does it affect mostly? Well, women and non-smokers. These are like the key terms for this carcinoma, and it rarely metastasizes, so it has better prognosis compared to, for example, squamous cell carcinoma. Second, you need to know about the squamous cell carcinoma, very strongly associated with smoking. Hence, we expect it to be more common in men, in contrast to adenocarcinoma. And since it is strongly associated with smoking, it is also a tumor mostly located in the central parts of the lung rather than peripheral, in the case of adenocarcinoma. And okay, so how does squamous cell carcinoma arise in the lung when the lung does not even have squamous cell epithelium? So what happens is, due to chronic smoking, your cylindrical respiratory epithelium is irritated and undergoes squamous metaplasia and gradually atypia, which finally results in squamous cell carcinoma in situ and then invasive carcinoma. And you need to know this whole procedure step by step to describe it to your examiner. And this is also a good example to, if you get the question metaplasia, which is part of the general exam question list, you can also give this example over there as well, because this is an example of metaplasia as well. So if you remember examples this way, these will help you with acing your questions in general pathology as well. Okay, the third type of carcinoma is adenosquamous carcinoma, two components, adeno and squamous, very obvious. Then the fourth and a big compartment, a big group of carcinomas are neuroendocrine tumors. What are neuroendocrine tumors? You must have studied that in general pathology. But here we divide them into neuroendocrine tumors and neuroendocrine carcinomas. Neuroendocrine tumors are more like sort of carcinoid tumors, typical, atypical. And neuroendocrine carcinomas are what we want to focus more over here. And therefore, they're divided into small cell and large cell carcinomas. Large cell are undifferentiated, no glands, no keratin, poor prognosis in smokers. Small cell carcinoma is the dangerous one because um, it metastasizes quite quickly, and it's so small that you cannot resect it surgically. You need to do chemo radiobiological therapies, and you need to remember the 4S of small cell carcinoma. So small cell and neuroendocrine in smokers centrally, and paraneoplastic syndrome, because it is a neuroendocrine, so you expect hormones being produced. So you will expect hormones like ADH or ACTH being produced. Um, this is just a reminder, where do neuroendocrine tumors originate from the neuroectoderm mostly, although it might be not clear in some resources. But if you ask your professor, he or she might name this neuroectoderm, but some professors might not be clear on it, as far as I can recall. But no one will fail you or make count it as a mistake if you don't remember if you don't remember that the whole pathway of neuroendocrine tumors, as long as just a neuroectoderm, for example. Okay. Carcinoids, like I said over here, typical, atypical. What is typical or atypical? Low mitotic activity for typical, and atypical is more malignant. So this is like the names of all the tumors present in the lungs. And now we move to the classification, which you need to know. And we will divide the tumors we saw on the previous slide under this classification, the classification of primary lung cancer with regard to prognosis and therapy. So why does LF1 focus on the classification small cell and non-small cell? Because it determines the prognosis and therapy of the tumor. Hence, we care about this classification more. So, what is this classification? Small cell carcinoma is the group which has just one tumor, which is a small cell carcinoma itself, which we saw in the previous slide over here. This one, just this, yeah. Uh, Whereas the other non-small cell carcinoma is the group which has all the other cancers which we saw on the previous slide. So adenocarcinoma, squamous cell carcinoma, large cell carcinoma, carcinoid, for example. So that makes it quite easy to remember. And like I said, uh, the therapy for small cell carcinoma is very different, and since it metastasizes quite quickly and it's very small, uh, not like you can't see it with a naked eye, it cannot be resected surgically. Whereas the non-small cell carcinomas have a different therapy method, including surgery and possibility of surgery. Hence, they have a separate group of classification. This is mentioned here in the note here. And hence, small cell carcinoma has early metastasis and bad prognosis. Very important to remember. And you do not have possibilities of surgery, so you go for chemo, radio, or immunotherapy. And for non-small cell carcinoma, you go for resection. Okay, now what could be the first possible clinical signs present in someone with lung cancer? You expect pneumonia, obviously, hemoptysis, dyspnea, chronic cough, unexplained weight loss, fatigue, inefficiency. So, unexplained weight loss is very common in most cancers, and hemoptysis could be somewhat specific to lungs, for example, and recurrent pneumonia is also an alarming situation. So, these are some of the signs for lung cancers. Okay, now, since I mentioned initially that secondary tumors are more common in the lungs than the primary tumors, but how can you identify morphologically which ones are primary or secondary? Like at least with the naked eye, you can suspect that is possible if you know that the cannonball nodules are present in the case of primary tumors. Uh, Sorry, the cannonball nodules are present in the case of secondary tumor, whereas the solitary coin lesions, like the smaller lesions, are present in the case of primary tumor, like in this picture. And here, this is a metastasis of clear cell renal cell carcinoma. So you can see like big nodules, and here you see sort of like small coin-like lesions, which is the primary here and secondary here. So this is something you will observe on autopsy, for example, and this creates a suspicion for which kind of tumor would be possible. Okay, next we talk about complications of lung cancer, very important. Seeding into the pleura, common in adenocarcinoma because it is peripherally located. SVC, superior vena cava syndrome, obstruction of the venous return. Of course, it's a tumor, it's a mass, so it may obstruct the superior vena cava. And then you will face superior vena cava syndrome symptoms. Then nerve damage, very common, recurrent laryngeal hoarseness, phrenic nerve causing paralysis of the diaphragm. Then if you have paralysis of the diaphragm, it results in death. And then you have the sympathetic nervous system chain compression, resulting in ptosis and hydrosis. Next, metastasis, of course, because it's carcinoma, neoplastic, malignant. So metastasis to where basically? Hilar and mediastinal nodes. You might be asked, well, what's the first location of metastasis for lung cancer? It is hilar and mediastinal nodes, and especially metastasis to adrenal gland. You need to remember this. Then other glands, of course, other organs, of course, the common ones. You would know breast, bone, for example, liver. But what's uncommon or like special is like unique is adrenal gland and the lymph nodes name you need to remember. Okay, this is just a picture of squamous cell carcinoma. I put this picture here just to tell you that you will mostly not be asked microscopy for any tumor, but for squamous cell carcinoma, you should expect that you may be asked the microscopy, like your examiner might ask, what do you see microscopically or under the microscope? And you need to say keratinous pearl, for example, reduced stroma with lymphocytes, atypical tumor cells, mitosis. Yeah, this is like sort of this is the classical feature of squamous cell carcinoma in the lungs, keratinous pearl. Um, Here, I just put a picture of neuroendocrine tumor, subgroup carcinoid tumor, um, which looks something like this, like a mass. Just for you to know that it looks like grayish white lesion or yellowish white lesion. So that's about it. We are done with this question. I mentioned all which you would need for your final exam, like the bare minimum as well as some additional points for you to be able to pass your question, hopefully.